through the other direct factors as IVH and PVL. I'm honored to be the author of the intracranial hemorrhage chapter in Gumella, 7th edition, and also the 8th edition, which is coming soon next month, inshallah. The brain ventricle structure, we have 4 ventricles. They are pointed from the front, pointed from the back, and pointed from the sides. They look like Star Trek. If anyone here watched Star Trek, they look like them. And when we bleed, when the baby bleeds, it most commonly happens because of weak arteries that are lining the ventricular germinal matrix. Very friable arteries that can spontaneously bleed or can bleed secondary to changes in blood pressure. And we know that after delivery, often preterm babies are exposed to lots of intervention from bagging, intubation, compression sometimes, and so on. So fluctuations in blood pressure and fluctuations in perfusions during resuscitation is very common. However, there is another common mechanism for IVH, which is venous infarction. Venous stasis happens due to multiple reasons, including pain, agitation, or a hypercoagulable state that can cause stasis and coagulation in the veins, increase in the backup pressure in the arteries, and then bleeding into the ventricle and or into the white matter, which is very close to the ventricle. The risk factors are many, including prematurity itself, rapid volume expansion, hypertension or hypotension, coagulopathies, HIE, RDS, low pH acidosis, and multiple other things. Most of the bad exposures within the first few days of life can cause IVH in a preterm baby. The pathophysiology, however, is simple. Decreased oxygen or hypoxia, increased CO2 or hypercarbia, decreased pH or acidosis can all cause increase in cerebral blood flow, and that in turn can cause IVH, which can be exaggerated due to multiple either genetic factors or due to the severe prematurity. So the more immature your germinal matrix is, the more likely you're going to bleed into your ventricles. And then this will end up with higher chance of having PVL and higher chance of having also ventriculomegaly or hydrocephalus. The incidence of IVH is probably in the first 4 days of life 95%, and within 7 days more than 99%, and in babies born less than 32 weeks, multiple numbers you get, but they are anywhere from 10% to 25%, and that's all grades. So from grade 1 to 4, that's about 10% to 25% in babies born below 32 weeks. And in babies born less than 26 weeks, the severe IVH, which is 3 and 4, can be up to 40%. This is horrific. This is very bad. Now, I think everybody here loves this photo, probably. Most of the people here probably would like this photo, right? This is called landscape photography. I love photography, so this is called landscape. And to produce landscape photography, you need a wide-angle lens, a DSLR camera, and settings in those cameras. So this is what I call the scene. The scene, and everybody wants that scene. He wants to shoot that scene. To shoot that scene, you need a tool. The tool is a camera, and the camera has settings. And those settings can be sometimes complex. So from shutter speed to ISO to white color exposure to lens size to f-stop, I can tell you at least 20 factors that can play a role in that image, in that photo. So it can be complex. However, some of the settings are more of high yield and more of direct effect on the quality of the image itself. Care bundles are like photography. They are the tool. The scene that you are looking at is a baby without disability or a population with reduced incidence of disability. The tool, which is the camera, is the changes in the quality of image or in the scene that you are seeing right now. The leading institution in the world and in the United States that's invented care bundles is the Institute for Healthcare Improvement in the United States of America, and the history of which started in 2001 when a group of ICUs collaborated, about 13 ICUs collaborated for improvement of reliability of healthcare provided in the ICU. This was adult ICU. And multiple projects were done. And what they came up with at the end is that there were two main areas for progress that were discovered: ventilation and central line insertion with those collaboration or common projects. And each area of progress that they discovered was noticed to have a high agreement among clinicians and a small number of independent interventions. Remember those two things very well. So high agreement and small number of interventions. We are talking here about 3 to 5 interventions. That's it. High agreement between or among the local practitioners. So as a group of people working in the ICU, they come together, they sit down, and they say, listen, we have a problem. We have a central line infection. How can we reduce that infection? Okay, we're going to put 3 or 4 interventions that help us reduce that. And those 3 or 4 interventions are the care bundle. They will be addressed all together at the same time, not as a single intervention or individual intervention. So the core idea of care bundle is when compliance is measured for a core set of accepted elements of care for a clinical process, the necessary teamwork and cooperation required will result in high levels of sustained performance or reliability not observed when working to improve individual elements. That's why the word bundle came from. A small set of interventions will be done together at the same time, in the same location, for the same patient. Time, location, patient, small group. If you do that, then you are doing a care bundle. Done. Now, to come up with the best care bundle, you have to customize it yourself for your own institution. It's not something that you should borrow from other hospitals because they have different procedures, different mechanisms, different policies and guidelines. So to address a problem in your unit or hospital, you need to come up with your own care bundle. 3 to 5 interventions, customized for your patient, so same patient, same time, and same location. Again, 3 to 5. Each bundle element is relatively independent. Okay? The bundle is used with defined patient population in one location. So we are talking here about preterm babies in the NICU. We are not talking about pregnant moms. Okay? So when you say a care bundle for neuroprotection, you should not include pregnant moms. If you want to include pregnant moms, then this is an obstetric care bundle. Okay? The multidisciplinary care team developed the bundle, so we should sit down together. The bundle elements should be descriptive rather than prescriptive. يعني ما تربطهم بشيء. Don't write it as a policy, write it as a guideline. So that leaves some judgment to the people working on the stage. Okay? And last thing, compliance of bundles is measured through compliance of all interventions together. So if a bundle is composed of 5 different interventions, if you don't do one of them, then you did not do the bundle for that patient. You have to fulfill all 5 or all 4 or all 3, whatever the number of the bundle is. If one patient didn't get compliance in one of them, then you are not complying for that patient. Khalas. It's all or none rule, because it is a bundle. Okay, that's the meaning of the bundle. Now, implementation, it should be, again, it's a local approach, and factors to take into account. Physicians, nurses should come together, sit down together, talk, and there should be sort of report that goes to the quality department, and probably you can use Excel sheet for tracking. Examples for care bundles, I think most of the audience here knows the most common care bundles probably are central line or CVC care bundle, and the probably less common one is the VAP bundle, the ventilation associated pneumonia care bundle. But there are others. There is surgery safety checklist, there is, Clostridium difficile, there is a VAP, palliative care bundle, a pressure area care bundle, sepsis care bundle, among other care bundles. Okay? So I hope everybody gets the idea of what a care bundle is. Do care bundles work in neonates? Believe me, they work. There is a lot of literature in quality journals around the world that show that care bundles are functional, are very effective in reducing harm and in reducing morbidities. This is one of them that says there is a substantial body of quasi-experimental evidence, and the word quasi means non-randomized, because you cannot randomize we don't usually randomize in quality improvement. To suggest that care bundles reduce CLABSI rates in the NICU. CLABSI stands for Central Line Associated Bloodstream Infection. Another one, successful implementation of bundle strategy to prevent VAP. Again, it has shown that it does work. And I have come across in the last couple months at least through 8 or 9 quality studies examining the effectiveness of care bundles in the NICU. They are effective. So we have talked about the scene. We have talked about the camera or the tool. Now, what are the settings that I can dial into that camera to bring me a better image quality? There are multiple things you can do from the neuroprotective point of view, but remember, you have 3 to 5 interventions to select from, and they have to be timely to the same patient in one location. To call it a care bundle, you have to fulfill those criteria. So small number of interventions in same time, same location, and same patient. Transport of preterm infants in utero is better than after birth. So that's something to reduce IVH. But is this gonna be part of my care bundle? Probably not a neonatal care bundle, probably a transport care bundle or an obstetric care bundle. So we're not saying no, it cannot be a care bundle. It just has to be titled appropriately. Perinatal outcomes, again, in England, they did the Epicure study for outborn versus inborn babies. Inborn have much lower incidence of IVH and other complications. Antenatal steroids, they are effective. Antenatal steroids prevent grade 3 and grade 4 IVH. I'm not going to go into details, but I'm just screening what can we do from the neuroprotective mechanisms to reduce IVH and improve disability. The strength of recommendation from the WHO about the use of antenatal steroids is strong recommendation. It does work. They do work to reduce IVH. Magnesium sulfate has been shown in one study to reduce IVH, in multiple studies to reduce also CP, cerebral palsy. Remember, your ultimate goal is to reduce disability, not just IVH. So magnesium sulfate is neuroprotective, and it does work. The tocolytics are not recommended by the WHO to prevent preterm birth. However, this is something that can be individualized per institution, following the guidelines, the incidence, the causes of the preterm birth, and so on. So this is something that you should not take for granted. There is, however, a strong recommendation of giving magnesium sulfate before 32 weeks of gestation as per the WHO. Delivery mode, it has been shown that C-section is actually safer to reduce the number of IVH. However, this is something, again, that's not very practical, exposing all mothers at 24, 25, 26 weeks for C-section just for the sake of reducing the number of IVH. Because there is another aspect, which is maternal morbidity and maternal complications. Significant IVH after vaginal delivery, again, this is a retrospective review. It does show that it's increased due to vaginal delivery. And again, as I said, the WHO does not recommend routine C-section for preterm birth just for the sake of IVH reduction. Now, this is something very interesting. Elevated midline head positioning of extremely low birth weight infants. Can this affect, can this reduce the IVH? It actually can. So maintaining a midline position while the head is elevated at 30 degrees angle has been shown at least in 3 different studies to reduce IVH and also to reduce death. In this study, it has shown to improve the survival to discharge here, and it did reduce the incidence of grade 4 IVH. So that's very interesting. I think this is something that's doable, right? Now, handling with care is another thing that you should actually consider. Minimizing stress and minimizing pain, but just remember that morphine has not been shown to reduce IVH. In general, narcotics, whether infusions of midazolam or fentanyl or morphine, those things are not associated with better IVH rates. The natural pain management, like sucrose or containment, is more effective. Sound and noise should be reduced in the NICU, and the American Academy of Pediatrics has its own recommendations of noise inside the NICU. There is a recent study about a year ago for a screening of noise in American NICUs, and about 75% of them failed to meet the AAP recommendations of noise within the NICU. So we have a lot of room for improvement. How about heated and humidified gas for resuscitation or for respiratory management of preterm babies? That is actually effective. Why? Because it will maintain the body temperature, and we know that hypothermia is another contributing factor for IVH. Ventilation itself, so the tidal volume you are using for ventilating your child. If you are using a high tidal volume with a bag and mask ventilation, more than 6 ml, it has also been shown to increase the incidence of IVH. There are some postnatal strategies. Phenobarb has not been shown to improve your IVH rate. Indomethacin in the TIP trial, which I think King Faisal was a member of. Barbara Schmidt is the PI of that trial. It's one of the most, I think, famous trials in neonatology. The TIP trial has shown less IVH with indomethacin prophylaxis. However, unfortunately, this did not translate to better neurodevelopmental outcome at 2 years of age and later on. And one of the theories that may explain this is that indomethacin itself, yes, it can reduce IVH, but on the other hand, it's neurotoxic. This is possible. We don't know exactly why, but this is just a trial of explaining why. So there's multiple studies also about should we use indomethacin routinely or not, and whether we should give it within the first 6 hours or not. So this is something that's still debatable. Indomethacin for preterm babies, it does reduce IVH, it does not improve long-term outcome. So the final conclusion of this that people say, listen, why don't you just give it if your own rate of IVH is higher than normal? Let's say the normal IVH rate for a 25-weeker is around 25% or 20%. Okay? Your own rate in your unit is about 50%.
2 minutes, Dr. Omar.
This is a good case, thank you. This is a good case for using indomethacin to reduce IVH. So if your IVH rate is the same as everyone else, so probably you should not use indomethacin routinely, especially if mom got antenatal steroids, because the incidence of bowel perforation is higher with the combination of steroids and indomethacin. This is very debatable. Ibuprofen does not work. Sodium bicarb, avoid. Please. Hypotension, multiple studies that permissive hypotension actually is safer than treating hypotension. You should not treat just numbers. It's more dangerous. Giving boluses also is not very safe. Saline boluses is associated with more IVH. So there are multiple things that you can do to neuroprotect your baby. This is not a lecture that talks about every single measure of neuroprotection. This is about a care bundle. It's about how to customize a care bundle for your own use in your own unit. So 2 examples for neuroprotection care bundle. One is from sick kids, and the population for that is less than 1250 grams in the first 72 hours of life, so the time and people or patient. This is their care bundle or brain bundle. And you can see here it's composed actually of 6 points. Gentle handling, supine and midline position. I can't read because the screen is too tiny. Head of bed elevated 30 degrees, maintain normothermia, minimize invasive procedures, and optimize ventilation. So those are 6. That's fine. هنسامحهم في واحدة. لكن the idea here is limited number, independent interventions, and all for the same baby, same time, same location. I'm about to finish. The last one is a Swedish intervention or Swedish care bundle, where they only use 3. So their 3 is maintain neutral head position again, with head of bed up to the highest position, which is about 30 degrees. No daily weights until day 4, and no holding or kangaroo care until also day 4. So remember, always in the baby in the first 3-4 days is extremely vulnerable. If you don't need to do an echo, don't do it. If you don't need to do a procedure, please don't do it. Even examination, I tell my residents and fellows, if the baby is stable and you don't need to examine, do not examine the baby in the first 3 days if the baby is stable, because we care about less disability. That's what we care about eventually. So in summary, neuroprotection care bundle is simple. It improves reliability of care. It does reduce disability. It must be evidence-based and limited to 3 and 5, must be independent, and can be used for different conditions or treatments and should be adapted locally. Remember the scene. the tool, and the settings. Thank you.
Thank you, Dr. Omar, for a nice presentation. Now we will invite our next speaker, Dr. Nahla Sheikh. She's a pediatric neurologist working in King Abdulaziz, Jeddah. And she was graduated from Saudi for pediatric neurology. Then she went to UK, finished her pediatric neuromuscular. She will present us today about neonatal stroke. Welcome, Doctora.
I'm very glad to be here with you today. Talking about perinatal stroke, the most focused lifetime risk of a stroke is the week surrounding birth. A term newborn carries a risk of a stroke that is greater than older children, almost 6 times greater, and almost actually tripling the weekly risk of smoking adults with diabetes and hypertension. After all, perinatal stroke lead to chronic neurological disabilities that amortize over lifetime. In this session, I will be highlighting the updates in the field and the consideration for clinical practice to prevent damage and promote health and recovery. Perinatal arterial ischemic stroke has been specifically defined by the NIH as cerebral vascular accident occurring between 20 weeks of gestation through 28 days after birth. And that is evident on neuroimaging data. The majority of perinatal stroke are related to arterial ischemic stroke, and the rest is related to cerebrosynovenous thrombosis and hemorrhagic stroke. Perinatal stroke actually shares many similarity or many features with older children. However, there are important differences. The risk factors in newborn are quite diverse and quite unique to their developmental stage. In neonates and also in older children, the physiology and the pharmacological response to stroke therapy is actually different. And the most critical difference here is that perinatal stroke primarily lead to change in the ability to acquire a function rather than losing one like in adult strokes. And the immediate outcome of this usually is not apparent in the short run, and that is because children usually grow into their deficit. The subtyping of perinatal stroke syndrome into 5 subtypes relies mainly on the important neurological neuroimaging feature. And that is quite important and relevant to outcome, and it's actually helpful to refine the perinatal stroke research toward more disease-specific state. But keep in mind that these stratification or classification are always changing, and different terminologies also do exist. Those perinatal stroke presenting in neonatal period usually or commonly present with seizure as the prime manifestation in 70 to 90% of patients, and usually in the very first 3 days of life. And that is actually the leading feature to trigger assessment and identify perinatal stroke. On the other hand, there are other infants who present later in life with asymmetry of hand, fisting, or maybe even frank hemiparesis. And in those children, we find a chronic infarct that is presumed but not proven to be happening during the perinatal period. Saying that both categories actually represent a similar disease or the same disease, the difference only in the timing of clinical presentation. The most potential risk factor for perinatal stroke are actually based on limited evidence from retrospective case series and doesn't really necessarily reflect a causal relationship. The multiple risk factors may include, gene environment interaction, maternal and fetal risk factors, or even the unique environment of the placental interface. All of these factors may interact synergistically to increase the risk of stroke in a given child. The recognition of prenatal stroke among other different possibilities of neonatal depression and seizures relies mainly on neuroimaging evidence of focal infarct. The diffusion-weighted images among all other regular or standard sequence and MRI is the most sensitive to detect early infarct and actually can confirm the close proximity to labor and delivery. In the majority of the children with perinatal stroke, we find it's actually in the territory of middle cerebral artery, and most of children they have a predominance of left hemisphere infarction. Actually, further diagnostic testing should aim toward other risk factors. In that regard, I just want to highlight the recent scientific statement from the American Heart and Stroke Association saying that there is a minimal association between the risk of thrombophilia and perinatal stroke, saying that this does not exclude the possibility of disordered coagulation at the time of the stroke, but suggests routine testing is not indicated. During the acute phase, all therapy is all about supportive measurements to reduce the risk of secondary brain damage. And there is no evidence currently for the hyperacute stroke therapy like thrombolysis and embolectomy that we use sometimes in children and adult stroke. The antiplatelet therapy such as aspirin and the anticoagulant therapy such as low molecular weight heparin is rarely indicated because of the low risk of recurrence of stroke in prenatal in neonates. However, there is an exception in those special neonates with, like, let's say, complex congenital heart disease or documented thrombophilia. Those children at high risk of recurrent stroke, standing almost to 14% risk of stroke. In those neonates with cerebrosynovenous thrombosis, particularly those with a clinical deterioration or those with evidence of propagation on serial imaging, those children, they need an anticoagulation with low molecular weight heparin. Well, beyond the neonatal period, the aim is to maximize the functional outcome, the long-term outcome. Early prediction of long-term neurological outcomes facilitates intervention earlier in the development. Clinical data, EEG, all can help to predict the outcome, but it's quite limited. However, brain MRI play an important role in the prediction of motor outcome, but to a lesser degree in cognitive outcome. So the simultaneous involvement of the cerebral cortex, basal ganglia, or the posterior limb of internal capsule is highly predictive of contralateral hemiparesis. The restricted diffusion and diffusion-weighted images at the level of cerebral peduncle, again, is predictive of poor outcome. And finally, the diffusion tensor imaging, or the DTR, is when it showed an asymmetry of the corticospinal tract, that is predictive of hemiparesis. Motor disability usually or typically emerge in the first year of life, with the frank hemiparesis in almost 20 to 25% of cases, and like mild motor deficit in another 30% of cases. The disordered sensation, or mainly the proprioception loss, is a major contributor to motor disability in children with perinatal stroke. The vision and visuospatial skills are actually not much studied studied, but however, the existing evidence suggesting that the high level of plasticity in the visual cortex may allow many children to escape this period without disabling hemianopia. The neuropsychiatric morbidities, including cognition, behavior, and other higher function, are almost occurring in 60% of cases. It is critical to understand that IQ testing in preschool children might yield normal scores, but if you do the scoring again at the time of school age, you will find a major deficit. The language development disorders occurring almost in 20% of cases. As I mentioned earlier, that the majority of perinatal stroke are in the territory of the left middle cerebral artery. The classic language area in the left frontal and temporal lobe are devastated or destructed. However, injury in the neonatal period may result in compensatory reorganization of the language connection, and many other normal brain areas may take the damaged area. Epilepsy rate is quite variable, but fortunately, most of the children with perinatal stroke, usually they outgrow their epilepsy. The recurrence risk is extremely low, accounting for less than 1%, except for those neonates with complex congenital heart disease. It's actually important to appreciate that the interplay of these multiple outcome measures is essential, or it has an impact on the eventual outcome in an individual child. For instance, a child with high capabilities to achieve a new motor skill cannot do that, maybe because of proprioception deficit, preventing him from knowing where is his limb in this space to control that motor function. Another example, or another child, let's say with normal mental capabilities, but he has like an attention deficit disorder that prevent him from engaging very well in therapy or school classes. Well, saying that life after perinatal stroke can certainly be good. The high level of functioning attained by majority of the children serve as an evidence for the powerful developmental plasticity. However, early injury may place many other children on the abnormal developmental trajectory with functional consequences. The relative impact of developmental plasticity on outcome actually is variable, and that's mainly depend on the fundamental aspect of injury, talking about the timing and location of injury. And it's apparent that for different developing neurological function, there are different critical periods of susceptibility to disruption. Animal and human models have constructed working models for understanding the developmental plastic motor organization following perinatal stroke. Let's say at birth, usually there is competition between the ipsilateral and the contralateral corticospinal tract projection to synapse with their target in the anterior horn cell and the spinal cord. But eventually, there will be the contralateral projection usually dominate with withdrawal of the ipsilateral projection. What happened after perinatal stroke is that there will be reduction in the contralateral projection with, and the ipsilateral projection take control in those children with hemiparesis, and that represents just a maladaptive plasticity. Saying that intervention that will act or that will enhance the contralateral or the lesioned hemisphere will enhance the motor control within these projections. And examples of these preventive or intervention is the constraint-induced movement therapy. Here, basically, it's a type of occupational therapy where we constrain the unaffected arm, so the child will have more, chances to use his affected arm, and that is, and it's actually evidence from clinical trials support the efficacy feasibility of this intervention, and it has been demonstrated to be feasible in children as less as 18 months of age. Beside the constraint-induced movement therapy, there is the transcranial magnetic stimulation by applying a focal current magnetic pulses over the skull to the underlying corticospinal motor neuron output. And this is a potential treatment, and there is a large evidence of tolerability and safety even in children, but the evidence for efficacy in newborn is still lacking or being established in the recent years. I want to conclude saying that we have a limited ability to develop preventive strategies, and the all evidence that we have for the antithrombotic agent is based on observational studies rather than clinical trial data. And last but not least, parent support and education has a major implication on their mental health for the long run. Just taking a minute explaining to the mother that this stroke is in no way her fault, explaining to parents that the nearly zero risk of recurrence and sometimes the remarkable positive outcome seen in later life, all of this can serve as an important intervention to engage parents in the long-term management with their children. Thank you very much.
Thank you, Dr. Nahla, for excellent presentation. As usual, I think the last presenter in this session is Dr. Amna Qashqari. She is a pediatric radiologist at King Abdulaziz Medical City in Riyadh, and her presentation will be in neonatal neuroimaging.
في أحد طلع لي presentation. هي في نفس الفايل بس أنا ما أعرف اللي قبل.
شو هي رسالة presentation. بسكريها all together. طيب خلينا شيء سكر لك إياها. المفروض إنها تتسكر ونروح
في نفس الفايل.
شو مشكلة بس. هذا نشوف هنا. فين الفايل حقك؟
ما أعرف.
سلايد ايوه هذا هو قلت خلاص ممتاز كذا.
السلام عليكم. My topic today is about neonatal neuroimaging. Actually, neonatal neuroimaging is a big topic, so I choose to talk about neonatal encephalopathy. No disclosure. Probably everybody knows the phrase that children are different and they are not small adults. And today we have to know that neonates are different and they are not small children, especially when we image the neonate. So my objective is to review the different modality in imaging neonatal brain, to discuss the clinical presentation and radiology of neonatal encephalopathy, and to emphasize on the role of neuroimaging to establish early diagnosis. Ultrasound. Of course, ultrasound, we always start with ultrasound. It's easy, available, cheap, bedside, no need of anesthesia, no need of sedation, and also there is no radiation dose in ultrasound. CT scan, of course, CT scan give us better imaging for the brain for the neonate, but the biggest withdrawal of CT scan is the radiation dose or risk of radiation for the neonatal brain. Though with the new multi-detector CT scan and also with applying a LARA principle during CT scan, it decreased the radiation dose significantly. But our target actually, if we have any case of neonatal encephalopathy, is to do MRI. And MRI, of course, has superior sensitivity and specificity, and it shows the brain in much, much better way than the ultrasound and CT scan. But MRI, we need a special preparation. It's a lengthy procedure. Sometimes we need sedation, and also we need MRI compatible monitor and support. So sometimes MRI is not available immediately for the patient. So what is neonatal encephalopathy? Neonatal encephalopathy is a heterogeneous syndrome characterized by sign of central nervous system dysfunction. There are multiple etiology, including HIE, neonatal stroke, neonatal infection, veno-occlusive disease, or inborn error of metabolism. Starting with neonatal HIE, so HIE is hypoxic ischemic encephalopathy. Everybody knows it's insufficient blood flow to the brain with decreased oxygenation, which lead to loss of normal autoregulation. So there is biochemical disturbance, hypothermia, and it leads to loss of vascular autoregulation. Neonatal HIE, actually, when we image neonatal HIE, it does not only depend on the etiology of the HIE, but it also depends on the patient or neonatal age. Is he a preterm or term infant? And the severity and length of the duration of the injury. So in mild HIE, when we look to a brain with a mild HIE from the history, we look in a preterm patient, mainly we look for periventricular leukomalacia or periventricular white matter injury, while in term infant, we look for a parasagittal watershed infarct. While in moderate and severe HIE, usually the affected area in the brain is the highly metabolic area, which include the basal ganglia, thalami, maybe periorlandic region as well. This diagram is a very nice diagram. It shows us actually the blood supply in the brain in the neonatal period in preterm and term infant, and how it is different between the preterm and term infant, that in the preterm the blood supply is mainly ventriculofugal, so it's toward the ventricle. That's why the preterm infant actually, they have periventricular injury or periventricular white matter injury. While in term infant, the blood supply actually, it goes away from the ventricle, so it's a ventriculopetal. That's why they have a watershed infarct. This is the first example of HIE, and this is clearly a preterm infant because of the figure of 8 appearance of the brain. There is no maturation of the gyri, and we can see clearly there is bilateral, almost symmetrical echogenicity in the periventricular white matter, which is sometimes reported as normal, and actually I always say this takes us to the history of the dress. Is it gray? Is it blue? This is because of we don't have a standard standard for the periventricular echogenicity. But all the time there are two criteria. We have to compare the periventricular echogenicity to the choroid plexus itself. So usually the abnormal white matter is more echogenic than the choroid plexus, and plus there is some area of sunray appearance in the white matter which indicate the abnormality in the white matter. For periventricular white matter injury or periventricular leukomalacia, we look for four grades. Grade 1, which is the periventricular leukomalacia, including echogenicity in the periventricular white matter. Grade 2, with cystic changes. Grade 3, the cystic changes seen mainly at the gray-white matter junction. And grade 4, the cystic changes extend into the subcortical region. The follow-up of PVL is actually very important, and most of the patients we see these changes in mild PVL, while we lose the volume of the white matter around the ventricle, and we have irregular dilatation of the posterior horn of the lateral ventricle. These patients most or quite often they just refer to us with developmental delay at the age of 2 years, and we have disappearance of the brain which indicate the presence of PVL during neonatal period, mild PVL, which was not detected or not imaged at that time. The other abnormality we look for in preterm infant is the intraventricular hemorrhage. And intraventricular hemorrhage, of course, is the most common pathology that we look for in our daily practice. And the intraventricular hemorrhage actually has also 4 stages. And the intraventricular hemorrhage, the pathogenesis of the intraventricular hemorrhage, that it's actually start in the germinal matrix in the ventricle wall. And why do we look for the codothalamic groove specifically? Because of the germinal matrix actually at this area is thicker than the other or the rest of the wall of the ventricle. That's why the hemorrhage actually started at that area. So for IVH, there is actually fragility of the germinal matrix vessels, decreased cerebral blood flow, and abnormal platelet coagulation lead to IVH. 4 grades of IVH, as we all know: grade 1 at the codothalamic groove, grade 2 intraventricular hemorrhage with no ventriculomegaly, grade 3 intraventricular hemorrhage with ventricular enlargement, and grade 4 the periventricular parenchymal hemorrhage. And the sequela of grade 4, it's of course bad sequela of grade 4 is the liquefaction of the intraparenchymal hemorrhage and development of the periventricular cyst, which is usually communicating with the ventricle itself. For a term infant, as we mentioned before, that the area of abnormality will include the watershed area because of the distribution of the blood supply. And in ultrasound, we can detect actually the watershed infarct by loss of the gray-white matter junction here. And we confirm it by MRI while we see high signal intensity on T2 and T1 weighted images and diffusion restriction in the MRI, which indicate the watershed infarct. Severe HIE, as I mentioned, it's mainly affect the basal ganglia in both preterm and term infant, and it has a predilection to the anterior lateral part of the thalami and putamen with sparing of the caudate lobe. And in term infant, actually it's more difficult when it is severe, but it only causes, it affects the posterior limb of the internal capsule, which we call it loss of high signal intensity in the posterior limb of the internal capsule. And the interesting part of the severe HIE in a term infant that it affects actually the normally myelinated tract. So we lost the normal myelination, and we can see the diffusion restriction in the posterior limb of the internal capsule and the brain stem along the corticospinal tract. Severe HIE as well can cause severe brain edema, cytotoxic edema with diffuse cerebellar cortical diffusion restriction. And actually in these cases, if we apply MRS or spectroscopy, we can see high glutamine glycine level or GLX complex. And the high GLX complex, there was a special interest in spectroscopy in the early years, but not anymore. And this area, which has high GLX complex, it causes apoptosis and damage of the brain. And this is for the same patient. We can see the subsequent images in 1 month that the patient has diffuse cystic changes and encephalomalacia, and we don't see or see any of the normal metabolite in the brain. So he has no NAA, low choline, and very high level of lactate, indicating the loss of the brain tissue. So pattern of HIE, as I mentioned, mild or moderate to severe. Mild, either periventricular ricomalacia, or in term infant is watershed infarct. Moderate to severe, usually it affects the basal ganglia as well as the normally myelinated tract. So the prognosis of HIE in term infant with mild encephalopathy generally have good prognosis and show complete recovery. 20% they have died during the period, the neonatal period, and 25 developed severe neurological deficit. The prognosis of HIE using MRI, actually, the long-term outcome with moderate and severe hypoxic ischemic encephalopathy can be predicted by MRI regardless of the hypothermia technique or not. So MRI, sometimes it's important to follow up the patient with MRI. Neonatal stroke, as we heard before, that neonatal stroke is a disturbance of the blood supply, and it usually affects certain territory, most likely middle cerebral artery, and it has a lot of etiology and risk factor. And this is a nice case of a neonate with congenital heart disease that it show complete infarction of the left side of the brain at the MCA territory, even it's confirmed by the MRA, and it showed the diffusion restriction. Neonatal veno-occlusive disease, of course there are many factors for neonatal veno-occlusive disease, including maternal causes, post-traumatic congenital heart disease, and it causes disruption and occlusion in the vein, and the superficial vein actually it's more difficult to be detected than the deep vein. This is another case from our institution. It showed diffusion restriction around the ventricular region at the distribution of the deep venous structure, and the MRB confirmed the presence of thrombosis and occlusion of the inferior sagittal sinus and deep vein thrombosis. Neonatal hypoglycemia, it's another cause of neonatal encephalopathy, and it's very important to diagnose neonatal hypoglycemia. And neonatal hypoglycemia when the blood glucose is less than 30 milligram per deciliter, and it's very important to know the characteristic appearance in MRI that there is diffusion restriction in the parieto-occipital lobe, which could be due to the variation of the glucose consumption, and it's mainly in term infant, and also it may cause excitotoxic brain injury. So this is the brain hypoglycemia, and it showed the diffusion restriction in the posterior occipital part of the brain. So this is very important because this injury is actually reversible if we detect it and diagnose it early. Neonatal inborn error of metabolism, my last talk, it's when we have atypical history of HIE, of course, it has non-specific clinical presentation, including hypotonia, seizure, metabolic acidosis, and diagnosis most of the time, of course, is done clinically and by biomedical markers. But even though the neonate is transferred into the MRI suite for further diagnosis or confirm the diagnosis. So neonatal inborn error of metabolism, actually they are monogenic deficiency in production, synthesis, metabolism, storage, or transport of biochemical compound, and they present in 25% during neonatal period. And general principle when imaging these diseases, that they mainly affect the white matter, as we know, which we call it leukodystrophy, but as well they can affect the gray matter, which we call it polyodystrophy, which is the basal ganglia, and it may affect white matter and gray matter. We call it polyodystrophy. So at this point, we have to know also the types of brain edema to diagnose IEM. So we have intramyelinic edema, which is the edema between the normally myelinated brain, and it's very easy in the term infant, as we know that only the corticospinal tract is the myelinated part of the brain. Vasogenic edema, which is caused by breakage in the blood-brain barrier, and we don't see vasogenic edema in inborn error of metabolism. And cytotoxic edema, which is astrocytic swelling due to abnormal sodium-potassium pump. The important part that both intramyelinic edema and cytotoxic edema may show diffusion restriction in MRI images. So usually, of course, the classification of inborn error of metabolism, it caused by etiology or the enzyme defect or so on and so forth. And actually, all these classification doesn't really help the radiologist to know which entity we are talking about. So this classification depends on the type of edema, because this is what we see as a radiologist. So if it is actually intramyelinic edema, so as I mentioned, intramyelinic edema affect the myelinated part of the brain, which is the corticospinal tract, or is it cytotoxic edema, or if there is no edema at all. So for intramyelinic edema, the most common example of intramyelinic edema is maple syrup urine disease, or actually all the acidopathy. It has almost the same appearance. So in ultrasound, we can see equigenicity within the basal ganglia bilaterally. And when we go to MRI, we can see the classic pattern of diffusion restriction in MSUD, which is involving the perilurandic region, posterior limb of the internal capsule, and extending into the brainstem and middle cerebral peduncle, and loss of normal myelin in T1 weighted images, and all these areas show high signal intensity on T2 weighted images. And when we apply spectroscopy, you can see the high level of alanine, which is indicative of increased amino acid. And this is, of course, it's pathognomonic for maple syrup urine disease. But all amino acidopathy also give the same appearance, which is a high signal intensity or diffusion restriction along the myelinated tract. The second example is non-ketotic hyperglycemia, and this patient actually one of our patients, which was diagnosed initially as MSUD, but when we go back to the MRI, MRI showed diffusion restriction also in the perirandic region, posterior limb of the internal capsule, brainstem and middle cerebral peduncle, and loss of normal myelin, of course, but we can see the abnormal orientation of the ventricle, parallel orientation, which indicate the presence of hypoplastic corpus callosum. And it's actually very known association with the non-ketotic hyperglycemia. But more importantly, actually applying MRS or spectroscopy, and in a spectroscopy we can see here in 3.6 level, there is a high peak, which is usually myoanisotol in long TE. But when we apply short TE spectroscopy at the same region, we're supposed to see nothing, no peak. But as long as we have peak also here, this is glycine. So this is a diagnostic for non-ketotic hyperglycemia. Afterward, of course, other entity that may give the same type of edema, which is intermyelin edema, which is a very rare, and even this case from the literature, which is neonatal adrenal leukodystrophy, and it gives the same appearance with diffusion restriction along the myelinated white matter tract. And last but not least, in intramyelinic edema is the respiratory chain type 1 deficiency. We used to call mitochondrial abnormality like it should affect the basal ganglia, but not anymore. Isolated respiratory chain type 1 deficiency, it actually present in neonatal period affecting the myelinated white matter, and it showed diffusion restriction along the myelinated tract, and spectroscopy showed double peak of lactate, and this is for the same patient. In 2 years of age, we can see the area of encephalomalacia and loss of volume and early cystic changes as well. So these are the causes of usually intramyelinic edema. If we think about cytotoxic edema and the patient again has no history of HIE, we have differential diagnosis either urea cycle or molybdenum cofactor deficiency. For urea cycle, we can see this patient in ultrasound, there is high echogenicity in the basal ganglia, and MRI show diffuse brain edema bilaterally, which is a cytotoxic edema. And the cytotoxic edema, as I mentioned, it's polydystrophy, so it affects the white matter and the gray matter. So the white matter show diffusion restriction, as well as the gray matter is affected and it show diffusion restriction, including the basal ganglia and thalami. And most importantly in this case, that the caudate are affected. As I mentioned, in HIE, caudate is less likely to be affected. So if we see the caudate is involved, we have to think about inborn error of metabolism. For molybdenum cofactor deficiency, also it's a rare disease, but it has a peculiar MRI appearance with diffuse cytotoxic edema affecting the brain. If we don't have the history and the patient has history of HIE, this could be a severe HIE. But as long as the patient has no clear history, this with high lactate level as well, so this may indicate molybdenum cofactor deficiency, and molybdenum cofactor deficiency as well, it gives early cystic changes in 1 or 2 months. Other causes of inborn error of metabolism like PDH, this is actually non-specific. It has no diffusion restriction or acute presentation during neonatal period, but when we do the MRI during neonatal period, you can see there is volume loss, subcortical cyst, dilatation of the ventricle, all these changes indicating that there is something happening in the prenatal period causing this brain injury. And even the spectroscopy, it shows you the lactate peak, which indicates the loss of brain tissue, low NAA and high choline. So all these images indicating the loss of brain tissue. So inborn error of metabolism, first it's a clinical suggestion, of course, with biochemical marker, and MRI came the last option. So for neonatal encephalopathy, we covered HIE, neonatal stroke, neonatal veno-occlusive disease, and inborn error of metabolism. So in conclusion, neonatal encephalopathy is a heterogeneous syndrome, need correlation between clinical, biochemical, and imaging finding. Diagnosis is challenging sometimes, and multimodality imaging approach needed most of the time. Thank you.
Thank you, Doctora, for this excellent presentation. Can we invite our speaker for question and discussion, please? Dr. Omar, Doctora Nahla. Any questions? Thank you, Doctora. Okay, is there any questions? Anybody want to? Oh. Yes, Doctor. Yes, sure.
Good afternoon. Thank you for the speakers and for the audience. My question is to Dr. Amna regarding the follow-up for HIE patients. What is the optimum time, and when I can say if the first investigations is not conclusive, when I stop here, I will not follow again. Thank you.
Okay. For ultrasound, we usually, if the ultrasound is normal, we repeat the ultrasound every 2 weeks, like a screening ultrasound. But if the ultrasound is abnormal, we can repeat it every week. We don't do routine MRI, of course, for intraventricular hemorrhage. But if the patient has other clinical presentation, hypoxia, any other indication other than IVH, like ischemia, we do MRI. So it depends on the physician. But then after the discharge of the patient, they follow up the patient by MRI for the prognostic factor, but not during the acute admission.
Yes, my question is regarding the prognosis, actually.
The prognosis. Well, the prognosis, of course, there are a lot of articles they wrote about the prognosis of the patient by MRI images, and they do DTI. But in our institution, or mostly in all institutions in Saudi Arabia, we don't do DTI to see the tract for the prognosis. But in acute setting, they depend on the prognosis and the presence of diffusion restriction or not, though even the diffusion restriction may normalize after the treatment in 5 days. So sometimes even the diffusion restriction is tricky.
Okay, any other questions? I have a question for you, Dr. Amna. What about the HIE? Do you have a specific time to do for them the neuroimaging? Which is, for the MRI, which is the best time to do for them, for HIE cases?
Whenever our physician asks for MRI.
No, but when it will be more accurate for us as a physician to diagnose this patient he's having HIE, and which is the best time for it? But some of them they are telling you can do it 3 days, but some of them they are telling it's better now to go up to 10 days.
Of course, doing MRI for a neonate, especially preterm infant, and he is 3 days.
No, most of them they are term babies.
Or even term, it's difficult to do MRI. So sometimes we delay doing the MRI from the first week, just for the patient's sake, to be more stable and so on, as long as there is no treatment. Like most of the time, if you think about it, the treatment is supportive treatment if you have the diagnosis. So HIE for neonate, we look for diffusion restriction or whatever in the basal ganglia. Usually we start with ultrasound. If the ultrasound is not conclusive, we go immediately to MRI usually. But if the ultrasound is conclusive, they may delay the MRI.
Okay, Victor.
May I just comment on the MRI? Two things. One, the timing has to do with the insult timing. So if you do it in the first 48 hours or 72 hours, you will detect the DTI changes, but you will likely miss the T1, T2 changes if the insult occurred around the time of birth. If you wait till 7 to 10 days, you will definitely have all the T1, T2 changes there. You will not miss them. You will not see the DTI changes. By that time, they will disappear. So the recommendation is just to do it at 7 to 10 days of age. Especially nowadays, we do cooling, so you already have cooled the babies, and then you have a chance not to lose lesions. You will probably not see the DTI changes. That's more important for the timing, for legal probably purposes, other than. So I think 7 to 10 days is what's going on now. The MRI now should be done in neonates without sedation. And many studies have demonstrated. We started that at Washington University in St. Louis because we're doing the research, and we could not have consent to do MRI in babies if we want to sedate them. So we started to wrap the babies and feed them and do the MRI, and found that successful. But nowadays, you'll find in literature many centers have demonstrated probably 97% success rate of doing neonatal MRI without sedation, with about also 95% or so very good imaging. And those who failed also, they can do them, try them again and being successful. So I think even in the state now, if you sedate a baby for MRI, you can be sued for that.
For that issue, the feed and wrap technique started a long time ago, actually, when I was a fellow in 2012. And the Boston Children's Hospital, they did this technique long time ago even. But in our institution, we failed to do this technique. And what they do there, they do it at night, at the moonlighting. So it's like an overtime cases booked at night at the time of the usual sleeping time for the neonate. So there will be no problem. But in our service, we cannot do it except during the working hours. And we tried to do it before, and we failed, actually. That's why we go back to sedation.
Any other questions? Okay. So thank you, everybody. Thank you. Thank you. Now I think we have to go for our workshop. Thank you.